Hi, everybody. A very good evening. And I am Sai Gayatri, and I've mastered in neurological sciences. And thank you for joining this webinar where we are discussing at length about stroke. I will not take much of your time because your time is more precious than mine. And let me quickly give an introduction of what we are going to learn in the next 45 minutes. It will not be a very lengthy webinar. Trust me, I'll only highlight on those points where you and I have not usually paid attention. And when I'm in a stroke case study, all of us do most part of the assessment really well. We all do sensory assessment, motor assessment really well. We all know components of how to test in a stroke patient. But there are some components which we totally forget. Well, we completely forget. And I'm here to focus on that. So let us quickly dive into this assessment. I just got one of my case study, but I will only tell you the gist of it, where the rest is for you to weave and then think around and wrap your head around it. So let me start sharing my screen. Right. I believe I am visible, as in my screen is also visible. Okay. Okay, I will start off. That's a very beautiful image done by my team. So thanks to my team for supporting me all through and bearing up with my tantrums. To start with the demographic data, quickly I'll just push you across or walk you through it. So his name is Mr. Thomas Kurian, 40-year-old male coming to the department with the left side weakness and speech difficulty and memory issues following a cerebrovascular accident episode. So he has been admitted in the hospital because of a CVA episode, and he has been under the treatment medically. After the vitals are stabilized, he has come to us. Straight complaint he had given us: I'm having weakness in my left side. There is speech difficulty and there's memory issue. He cannot remember things. He's a right dominant and he's diagnosed with a CVA with right MCA infarct. The assessment was done. That's the latest assessment that was done. And Thomas has experienced a sudden onset of left-sided weakness, facial droop, and difficulty in speaking because he is an IT employee, and then he had come home just he had just come home, and that's when he developed a sudden onset of left-sided weakness and facial droop, vomiting, severe headache. He was taken to the emergency, diagnosed with ischemic stroke with right MCA. When I mean left-sided weakness, it's a right MCA infarct. And thrombolytic therapy was administered. Nothing much. See, he already had a transient ischemic attack episode 8 months prior to this. It's the second episode. Luckily, he was again rushed on time, wherein the doctors could give the TPA factor, the tissue plasminogen activator. That's when the thrombolytic therapy was also done and administered during the therapeutic window. You have the window period, right? About, say, maximum 3 to 6 hours is the window period, or maximum 4 to 6 hours is the window period, within which if the patient is brought, he or she can be completely curable and they can go back home happily. But since it's a second episode, he started developing weakness. Now, what aspects to check in him? I have just given you the history of presenting illness, and then he had come to an emergency, and then this is the non-surgical treatment, and then he has come to you for therapy. All he says is, I have weakness on my left side. I'll again go back. Left-sided weakness, speech difficulty, memory issues. He keeps forgetting. Okay, simple. What aspects to check? Flag system is one thing where we usually do not pay attention. When I say flag system, there are so many conditions in the history assessment or in the history taking that you and I usually do not pay 100% attention. We ask these questions, but it is very important for us to write them down as a part of documentation. Yellow flags, check for any anxiety or depression in the patient. Red flag is where you're not supposed to touch the patient at all. For example, say uncontrolled vitals, uncontrolled hypertension, severe vomitings. You can't give any therapy. That's a red flag. Since it's a clear cut no, I'm coming to a yellow flag, where yellow flag means a depression or anxiety. Blue flags is ask about the previous work environment. How was, see, I would ask Thomas, how was his previous the job before the injury? What kind of work if he would have, if was it a monotonous work, or was it a dynamic work, or was it under pressure, or what were the issues that he was facing, and did he have any job satisfaction? Okay. And then the black flags. When I say black flags, the economic status and the financial status is what we'll have to consider. The economic status of the patient, any legislative issues, any land issues, where any financial crunches, any social problems, where wherever he is living or wherever he is working, anywhere if he has any legal issues, all those also have to be considered because they play a very big role, or they play a very important part in rehabilitation. Okay, next. This is a flag system that you have to consider. Mind you that flag system, basically, there's one study that has happened this was done by my guide, my master's guide, where my sir had done a study on the level of socioeconomic status and level of motor recovery in upper limb. What a fantastic thinking. I mean, I have never seen across that an economic status can impact the motor recovery. Correct. And it is very, very surprising to see that higher the economic status, lower the motor recovery. There was one study, my sir had done multiple studies in this, but in one study he has seen, I mean, why am I giving this is for you to improve and you can work on this. That people of very high socioeconomic status are having, did a very, very poor improvement in motor recovery for upper limb after stroke, because they were too much, they were pampered, and their family members were disablers rather than enablers, and their activity limitation was very high, as in they wouldn't participate in any activity because they would think, see, I have everything, why should I even participate in an activity or do an activity myself? So the economic status plays an important role. And on the contrary, people with a mediocre economic status or a modest economic status had a best recovery, because they end up being the bread makers, they end up being the winners of the family. So they have to get back to livelihood. So these flag systems play a very important role. After that, then Thomas' existing comorbidities were hypertension. Thomas has been hypertensive since 5 years, type 2 diabetes since 3 years. He's a non-smoker, but as I told you, 8 months ago, he had a transient ischemic attack. But he has been cured immediately because of the thrombolytic therapy and TPA, the injection. What will you do? Normal pain assessment. I'm not here to tell you the pain assessment because you're well aware of it. The kind, type, site, body chart, aggravating relieving factors, sensitivity, irritability, and the NPR scoring, the visual analog scoring, body chart scoring, McGill pain questionnaire. These are very, very commonly used and very well aware subcomponents under pain. Therefore, pain assessment is very easy. I need not tell you what a pain assessment or how a pain assessment has to be performed. After you do a pain assessment, it's understood that you have to observe, correct? So under observation, TPR-BP, this has been, I was taught by one of my doctors where I used to work. So it's a very beautiful abbreviation for me to remember, because TPR-BP, how would you remember otherwise? Temperature, pulse, respiratory rate, and BP, blood pressure. So just the TPR-BP will do. You need not remember too much in detail. You'll check those, you'll check the synergy patterns, you'll check the tracheostomy. Yes, or if the tracheostomy has been done or no, or actively, even if you're seeing if there is tracheostomy or no. You will also see for deformity, tightness, and impairment. So when a patient comes to you, you will check if there is any deformity, or even in Thomas, I would see any deformity. But surprisingly, Thomas did not have any deformity. Thomas' synergy pattern was also very, very minimal. He, more than having a synergy pattern, he had paresis. It's a hemiparesis more than hemiplegia. Therefore, the synergy component or a deformity component wasn't there. Tightness component wasn't there. There was impairment because there's weakness in the muscle because of paresis. Paresis is weakness. Plegia is spasticity. When the spasticity breaks in the brainstorm stages of recovery, you have the 7 stages of brainstorm stages of recovery. When that breaks, what you encounter is a paresis. When I say paresis, it is the weakness in the muscles where the spasticity has been broken, but you will still encounter weakness in the muscles. Muscle wasting, Thomas had a very mediocre muscle wasting. He was very, very obese when 8 months before the first episode. But for the second episode, he lost about 12 kilos. And since the second episode was also quite mild, and then he developed other perceptual disorders. Surprisingly, even if it's a left side weakness wasn't much. The speech and memory issues were very high. You will see as we go forward. Palpation, what all do you check under palpation? I would check skin integrity, muscle tone, any injuries, any tenderness, gradings of tenderness, edema, gradings of edema. I'm not writing all of this because you know all that. Okay. These are the usual palpation parameters. There is no special parameter for palpation. Examination, we will first have to see GC scoring only for unconscious patients. When I go to colleges as an examiner, students, I cannot blame the students. They when I ask the same question, they would say first point in examination is GCS. Even if the patient is conscious, walking to you and sitting in front of you and talking about their problem, you cannot check for GCS because GCS is done only for unconscious or semi-conscious. That's when you go for coma stimulation, right? Based on the GCS scoring, you'll go for coma stimulation. If I have to go for coma stimulation, patient should be eligible for that coma stimulation, which means patient shouldn't be conscious or should be hardly any conscious. Therefore, GCS is done only for unconscious. So Thomas, it was not necessary. He was telling me himself about his own problem. He was more clear about his problem than me myself. Cranial nerve examination, all the 12 pairs of cranial nerves. I'll not take that in detail right now because today I want to focus more on the outcome measures that we do. But if you really want another webinar on cranial nerve examination, please do write to us and we will arrange a webinar or a workshop based on your response and your doubts. We can arrange another session where I'll talk at length about cranial nerve examination. So 12 pairs have to be tested. Even if Thomas has come to me with all intact 12 pairs of cranial nerves, I have to test because you cannot negate without testing. Only if you can test can you tick mark and nullify and then rule out those parameters. Sensory examination, superficial and deep. Superficial, touch, temperature and pain. Deep will be kinesthesia, proprioception, vibration, pressure sensation, crude touch, and superficial reflexes. All the subcorneal reflex, crematoric reflex, abdominal reflex, you have to test. Even if they come as negative, please do test. Motor examination, under motor examination, if there's a spasticity, you will have to test for modified Ashworth scale because it's an increased tone. And you'll check for synergy patterns. Upper limb, what is a synergy? Dominant synergy is a flexion synergy. Lower limb dominant synergy is an extension synergy. Write down the components. How is a trunk? Is a trunk dissociated from the upper limb and the lower limb? Again, I reiterate, trunk has to be dissociated from the limbs. Only then that is the prognostic point of recovery. Because when you are moving, your trunk is not moving along with your limbs. Your trunk is stabilizing, then your limbs are moving. In them, the trunk and the limbs move en masse. Hence, that is why we call it a synergy. Otherwise, if there is dissociation, then why do we call? In Thomas, there was no synergy pattern because I told you it's paresis. Therefore, there was no trunk dissociation. There was trunk dissociation in him. He could walk. All he could walk was dragging it because of the weakness of iliopsoas, he cannot lift his leg up, and then because of weakness of plantar flexors, he couldn't go for a heel strike. Having said that, he wasn't doing a circumductory gait. He could do a knee flexion isolated. He could do hip flexion isolated. But if he has to do a combined hip knee ankle, that's when he would fumble. Therefore, you'll check for muscle girth, you'll check for tone, deep tendon reflexes, Babinski's sign. In him, Babinski's sign wasn't there, it was negative. But otherwise, if it's positive, then you have a proper synergy pattern where the Brunstrom stage is about 3. Stage 3 of Brunstrom, where spasticity sets in and spasticity reaches its peak. We'll talk about another grading parallel to Brunstrom stages just immediately after this. And yeah, that comes on motor examination. So that's why I haven't mentioned, because you and I know what to test under sensory and motor. Higher mental functions, Mini mental state examination. MMSE is one widely used outcome scale for higher mental functions. Very easy to administer also. But along with MMSE, you have something called as Montreal Cognitive Assessment. It's a very beautiful scale. From here, we'll start seeing scales, guys. Okay. So I'll tell you one or two scales. It is not a hard and fast rule. You have to apply only these scales. Whatever is available in your research material, whatever is available in your department, whatever is easy for you to administer, you can pick those. These are some which I find it easy to administer because they're not very time taking. They do not require heavy equipment. I'll tell you what heavy equipment means. When we go for coordination, no, that time I'll tell you what kind of scales would require a heavy equipment, what kind of scales would require very less equipment, and then you can do it without any equipment also. Montreal Cognitive Assessment has a scoring of 30, and this will also have the same parameters of MMSA like naming, recall, attention, repetition, alertness, sequencing, and arranging a sequence as in dots, dot counting or joining the dots. You find the numbers in a puzzle, and then you have to join the dots with the numbers. See, 1 is here, 2 is here, 3 is here. You have to connect 1, 2, 3, and 4 is somewhere here, and 5 is somewhere here. You have to connect. So these are parameters in Montreal Cognitive Assessment. You have a PDF available. Everything is available on the net. Again, these are not paid outcome measures. These are free outcome measures that I'm going to talk. You can just go on the Google, type this, and you'll get the PDF. You can implement. Yeah. Cortical sensations. We know what cortical sensations are. Graphesthesia, barognosis, two-point discrimination, tactile discrimination, double simultaneous stimulation. We all know that, and that's why I haven't mentioned here. Thomas was good in all these, but Thomas was a little poor in stereognosis, so he had a stereognosis. And Montreal Cognitive Assessment, he was good, but in recall, he would fail. MMSC also recall, he would fail. Repetition, he is good. Language, he is good. He's excellent in language. He would talk better English than I would do, but he had a problem in recall. The recall is a problem. I'll tell you so that you can. And why do we do these tests? Is to also assess for short-term and long-term memory. Okay. Thomas had an excellent long-term memory. He would tell his date of birth, his spouse, his kids' date of birth, where was his first job. He belongs to Kerala. So which village in Kerala also he would tell. But if I ask him, okay, let me not break the suspense right now. He had a short-term memory loss. The recent memory is what he would fumble at. Long-term memory is excellent. So these MMSE and Montreal cognitive assessments will also test for your long-term and short-term memory. This is what I meant by VMC grading in under motor examination. This can come under either under motor or a separate entity after the motor examination. Just as you have your 7 stages of brainstorm stages of recovery, you have voluntary motor control grading. This voluntary motor control grading, you have to assess in every stroke patient who comes to you with a definite spasticity. Who do not come to you with a spasticity are paresis. They have a separate set of tests that to be done. But test even in them also, you will have to test for voluntary control grading. This has 6 grades. So the 6, yeah, it has 6 grades, which will denote the level of spasticity, if the spasticity has been broken or no. You have brainstorm stages. The 7 stages of brainstorm stages are very tedious. For example, in a stage 5 of brainstorm stage of recovery, you have to ask the patient to sit and to move the foot front and back with the hips and knees 90-90. The foot should be moved front and back. And then, the patient is supposed to touch the abdomen and then the back of the head, or, do this. It becomes a little difficult for you to remember and for the patient also to execute. But this is a very simpler scale where 6 grades, grade 0, as usual, no contraction, grade 1, as usual, flicker. Grade 2 is half range of motion in synergy. Beyond that half, the limb cannot go in synergy, which means the limb is rigid. Grade 3 is full range of motion and synergy. Whatever you ask, if you ask the patient to perform shoulder flexion, he or she can do it in synergy, but he at least goes till here. This is grade 3. Grade 2 is till here he would do, and then he would say, I'm sorry, I cannot do it beyond this. Grade 4 is where it has improved. Initial half range of motion in isolation. You wanted shoulder flexion. It's okay, my face is cut because my priority is on the shoulder right now. You wanted the shoulder flexion, isolated shoulder flexion. So initial half range of motion would go normally and then would pick up like this. If you can notice, this is grade 4. Okay. Grade 5, full range of motion in isolation, but with resistance, it goes back to synergy. So if you ask, see, it's a long lever, so I have to show it in a short lever. If you ask, it will go completely. But if you put resistance, if you say, okay, push my hand, push my hand, push my hand, push my hand, it goes into synergy. Okay. Grade 6 is full range of motion. Even with resistance, it goes in isolation. So the moment patient touches grade 6, he or she has been recovered from the spasticity pattern, and it's for you to start strengthening. Because as long as the patient is in grade 3 or grade 4, you have to start with PNF, you can start with NDT, you can start with any enmasked movements, you can start with motor functioning exercises. When I say motor functioning, normalizing the tone, go for inhibitory techniques, work on the tone, work on the tone, work on the tone, go for close kinematic chain exercise, go for weight bearing, then parallelly go for PNF mass patterns, play between hold, relax and contract, relax, play between isometric reversal hold, all of these. But when the patient comes to grade 6, start with strengthening, give him weights, start doing isolated joint resistance movements with manual or mechanical weights. This VMC grading tells you a very clear picture about the recovery level in the stroke. After this, another beautiful component that usually we miss testing and we have to test is apraxia. Apraxia is difficulty in doing an activity. Simple. If I ask you to get vegetables, very simple. I use this example everywhere because it's easy. It's the day-to-day activity that we do. Or if I ask you to make a soup for me or fix a sandwich for me, you know the process. You know what ingredients are required for a sandwich, how should the process be, what should be chopped, what should be decorated or kept in between the bread slices, and what should be done. All of that you are aware of. So making a sandwich is an activity in itself, is a complete activity, but there are specific components or steps in it. So each step is a work in itself, correct? See, you just can't say sandwich is one activity, but picking up vegetables for it, picking up bread for it, chopping them, arranging them, correct? All of that is also a part of fixing a sandwich. Inability to do this is apraxia. Okay. When I say idiomotor apraxia is where a person can do an activity by himself. But if you ask him to do, he or she fumbles. They cannot. Idiomotor, which means if the person is thirsty, he can go and fetch water for himself from the water bottle and he can drink. But if you ask him to do, that's when he will fumble. He wouldn't be able to do. He'd find it very tough to either initiate or to continue. Ideational apraxia is where he does not have an idea of the list or steps of an activity. Even if you tell him or even by himself, he or she cannot formulate the steps. Okay, if I'm thirsty, if I have to drink water, what should I do? I should get up, go open the water bottle and then put in the glass and then drink. This steps he cannot ideate. And then even if you tell him, he cannot or she cannot execute that. Limb kinetic. They cannot perform. Limb kinetic apraxia is where a patient cannot perform automatic activities with the limbs. For example, if I am writing or forget writing, if I'm eating something, okay, and then the spoon falls into the bowl. What do? I pick it up. I naturally pick it up. Or if there's something spilling on my hand, I use my other hand to wipe it off. These are involuntary movements. No one tells you to do that. But the other limb or this limb and this limb has, my right hand, left hand has coordination in a way that if something spills, I can wipe it off. Right? Or if I have to scratch, I have my other hand to scratch onto my right hand. This is a limb kinetic apraxia wherein patient cannot do these stuff, where the involuntary movements of the limbs Does not happen. Correct? Now, if you have to tie your shoelace or if you have to wear your shoes, after your right shoe, you'll go for your left shoe, definitely. No one has to tell you that. But these people find it difficult to do that. Buccofacial, any oral activities, which means if they have to talk with the mouth, lips, anything they have to do, they find it difficult. Any oromotor activities, talking, drinking, brushing, eating, and drinking juice. These are certain activities where they require, see, there are some activities that require your lips and the tongue both. There are some activities that require only the lips. This sync is what they miss. That's a buccofacial. So they cannot differentiate between eating and drinking. They cannot differentiate between drinking a soup and drinking, say, a juice. Okay. And constructional. If I give them an activity, when I say, okay, please dress up, they have to construct. And I ask them, what can be the steps? Tell me the steps. They cannot do that. For example, if I give them blocks and then they have to construct a building, they cannot do that. Or for example, if I give them a house, draw me a house, they have to they have to draw. They cannot do that. Okay? That's also called as a drawing apraxia, but also constructional apraxia. Dressing apraxia is a typical apraxia where I notice so many dressing apraxia patients where they cannot dress up, buttoning, tying shoelaces, cufflinks, right? For if they are ladies, if to put these pleats of for saris, right? These pleats, they cannot do that. Very sensitive and subtle. They, for us, it might not be important, but they're actually very important for them. Gait apraxia, where they cannot have an initiation, or even if they have an initiation, they cannot maintain the gait. The maintenance of gait is a problem. For this, I've got two scales. One is Apraxia test battery for adults, while this Apraxia test battery for adults tests some of the parameters like your dysdiadochokinesia, what is the rate of dysdiadochokinesia. We ask the patient to perform alternating movements, and what is the rate of that is what we test. Ability to produce lengthy sentences. How lengthy can they talk? How long can they talk? How continuously can they talk is what we test. We test for oral apraxia and limb apraxia. Again, oral apraxia is where we ask them deliberately to do movements only with the tongue. For example, showing the tongue, sticking the tongue out, touching the tongue to the upper lip and the lower lip, touching the tongue to the corners of the mouth. Similarly, limb apraxia, sudden involuntary movements, as if I'm going to hit him and he has to protect himself, self-defense, or any sudden tap I do, or any sudden hit I do, and he's supposed to rub as a response. Sudden involuntary movements, we test them. If they're not able to do it, then we have a separate scoring. I'm not getting into detail of that. Just remember that there are certain outcome measures for you to test this component. That's apraxia battery for, and time delay. Any latency period in doing an activity or in talking or in response, we check the time delay also. The latency period in pronunciation also, we check in apraxia battery for adults. Western aphasia battery is where we check for repetition, naming, ability to understand the language, ability to respond in that same language or in his or her own language. Even if I talk to you in English, if you can respond to me in your mother tongue, if it's Hindi, unless I know your mother tongue, it's you're good. We're on the same page. But if I'm talking to you in the same language and yet you're not able to respond, that's where we'll have to think. Or if I'm talking in a common language where both of us know, but you're not able to respond. That. And spontaneous speech. We also test for spontaneous speech, which means the patient is supposed to spontaneously ask or talk about a topic, or he has to add his own value or her own value by in the conversation that you are having. And that is what we test in Western aphasia battery. Naming the objects also we test on this. So these are two outcome measures, basic outcome measures. You also have buccofacial aphasia battery. You also have oral and limb apraxia aphasia battery. Apraxia battery. These outcome measures for apraxia can guide you in quantifying the type of apraxia that we just discussed. too much of apraxia, but now it's time for my favorite, which is agnosia. Agnosias are because of parietal lobe dysfunction. These agnosias are usually a perception disorders, which means the understanding. Perception is always means understanding. How are you understanding what the other person or the universe or the life is throwing at you? For a simple lack of better words, understanding of what's happening to you is perception. Correct? These people, when especially if there's any frontotemporal or frontoparietotemporal infarcts, that's when their agnosias will be coming out and they have a high impact on the parietal lobe, because your parietal lobe is very important in recognition, perception, response. Very, very, very important. The types of agnosia will be visual agnosia. They cannot differentiate between the objects, between people. No, they have visual agnosia. They just cannot differentiate. Auditory agnosia, they cannot differentiate between various sounds. May it be their spouse, or might be their children, may be another new person, or might be animal sounds. They cannot differentiate. Tactile. Usually, you and I we will know the touch of our parents, of our siblings, of our best friends. We know how they feel when we touch them or when they touch our hands. But these people cannot. They fail to recognize. Like Thomas. Thomas only can recognize his wife and his children. He cannot recognize his mother and father. Okay, so he has tactile agnosia a little bit. Anosognosia is a very critical component to treat and a very tough component to treat also, because it is otherwise called as hemi-neglect, where anosognosia is wherein they fail to recognize one part of their body. They only think that they only have one side of the body. They do not have the other side of the body. So, if Thomas was a hemi-neglect, he would only think that he had right side. It's a left side weakness, correct? Because right MCA infarct. This is my right side, by the way. So, because of which he would think that I only have my right side. And then they would also place their objects onto their right side. They will place their favorite toys and they'll place the television, they place their writing pad, or they'll place their phone, everything on the right side. They would want their family members also to sit on the right side. And Thomas would only initially, if he was the main neglect, he would only ask his spouse or his family members to sit on the right side. Left, he wouldn't. So much so that if you ask them to identify an object, they'll only identify. If you give them a picture, for example, a garden, and if you ask them to identify the number of roses, if there are 20 roses in that picture, and if there are 3 roses in the right side and 17 roses in the left side, they'll only tell you 3. They'll not tell you the remaining 17. That's how severe can hemi-neglect go to. Anosognosia becomes very tough to treat. You will have to treat the perception first, and then you have to treat the left side parallelly, agreed. But along with that, the objects and the manipulation from right to left or from the good side to the weak side takes a lot of time, a lot of toll on the therapist. Therefore, anosognosia is one very important and one crucial type under agnosias. Somatosensory agnosia, where they cannot understand what object are they touching or what fabric are they touching. For example, see, it can come under tactile agnosia only, but tactile agnosia is confined to, say, people touching them. But somatosensory is they going and touching. So if I ask a patient to go pick up sand, okay, and just without the gravel or without the stones, just the fine sand, he should be able to identify, but these people do not, because the somatosensory input they cannot get, although they're touching the sand, although they are touching the stones, although they are touching the gravel, they feel everything is same. They cannot tell the differences between. Okay. Prosopagnosia is faces, failure or inability to recognize familiar faces. And you might ask me, what is a treatment for this? Repetition. Repetition is the only treatment. Constant input or constant feeding of the same stimulus to the brain, that's when the auto firing would happen. Here you have scales for agnosia also. This is visual object and space perception battery. In this, we give them or we identify any drawings and silhouettes, and we ask them to recognize. When I say silhouettes, it's just the black outline. For example, if there's an apple, I only put a black outline in the shape of an apple, and then he has to recognize that it's an apple. He has to name the object that it's an apple. Or if I just put a candle, half candle, he's supposed to recognize it's a half candle, not a full candle. If he says it's a full candle, that's when it's a hemi neglect. Because you cannot, if you're a normal person, you'll only talk as a half candle. If he is not having a hemi neglect, he'll talk as it is a half candle. But we give incomplete objects deliberately for them to identify and for us to understand that they are identifying it as a half object. We give them a half cut tree. We give them a half cut candle. We give them half incomplete building picture. They have to identify. That is visual objection and space perception. In space perception, we give them dots and they have to count the number of dots. In a plain paper, we give them random dots. They have to just count the number of dots. How are they able to understand the spacing of the objects and how are they able to talk is space perception. Pyramids and palm trees test. Very interesting test wherein you give them palm trees, you give palm tree and you give a pyramid. And although they look vertical, correct? Palm tree goes vertical, pyramid also goes vertical. They are vertically placed structures, but they should be able to identify what is a palm tree used for, what is a pyramid used for. What is the significance of a palm tree? What is the significance of a pyramid? This differentiation is what if they can tell, that comes under pyramids and palm tree test. Bend and facial recognition, as the name says, he has to understand or ability to recognize faces and differentiate between the faces. Here, as the test progresses, we give them faces of various geography areas like Africa, like Korea, Japan, China, India, Asia, Europe, Australia, such complex levels where they have to identify, but simpler levels, we give them their family member faces and they have to identify and they have to differentiate who belongs to him or her and who do not belong to him or her. Okay. Thomas had naming agnosia. I have to tell you this incident. So when I do almost 1.5 hour sessions with Thomas, right, every day. Therefore, during those sessions, every day he would come in the morning at 10 o'clock and I would ask him, Thomas, what was your breakfast today? If it is idli, he's so smart. How would he tell me is, so doctor, I ate something. It is dry. It's white in color, but I'm not able to get the name. It's white and it's white. It's round in shape. I had two of those, and I had with some gravy. But you eat it every day, especially in South India, you get it more. And I we eat it almost every alternate day. I'm sure you know it. You should tell me the name. These are what he would say. And if it was a bread, no, it's something white, square shaped, where I had to apply something, and then I'm not able to recognize what I applied, but it's sweet. Whatever I applied on it, it was sweet. When I ate it was sweet. This is, it's for simple bread, he couldn't name it. And the first case, it was idli. He couldn't name it as idli. He would go around the idli, but he wouldn't name the idli. That is naming agnosia. Many patients come to us with naming agnosia, where it is your duty for them. And I told you, right, in the initial session, the starting itself, that Thomas had recall issue, recalling. Recalling the name idli was a problem. Recalling the name bread and jam was a problem. He would apply jam on the bread, he would eat. He was given to eat. He would eat by himself, but he cannot remember what he ate. That is naming agnosia. And for that, you have to go for visual objects and space recognition, space perception battery. Balance and coordination. You check for sitting and standing balance, static and dynamic balance, yes. And you have to also check for strategies, what kind of strategies we have, the hip, knee, stepping strategies, give perturbations in check. Work balance scale is a fantastic scale. We have 14 components and a score of 56. Where work balance is a standalone scale for balance if you have no other. CTSIB is very, very good, which I used in my study, but If CTSIB is tough for you to perform, just go for BBS, Bug Balance Scale, sitting unsupported, standing unsupported, sit to stand, standing and turning the head, standing and turning full 360-degree. Correct, standing on one leg, standing on toes, standing on heels, standing on tandem stance. All these are covered under Work Balance Scale. Next comes clinical test for sensory integration and interaction on balance. This has 6 components and total score of 120. While 2, 2, 2, it's bifurcated like that. And here you have eyes open, eyes closed. Standing on firm surface, eyes open, eyes closed. Standing on foam surface, eyes open, eyes closed. Standing on foam surface with a dome attached around the head of a patient with eyes open, eyes closed. So you only check from simple to complex moving platform with complex vestibular input, and we check for balance. So both BBS and CTSIB have excellent validity and reliability, and you can check, you can use these for balance. There are other scales also for balance, but these two are easy to administer. Hence, I got these. Other components of balance, you already know them. You need not worry about them so much. Coordination, you have your equilibrium and non-equilibrium coordination tests. You have the set of tests, both under equilibrium and non-equilibrium. Remember those tests and perform on every UMN element patient. It is necessary for your protocol. You should know what set of equilibrium and non-equilibrium tests is the patient performing. Scales for that, if you cannot perform these tests, if they're too lengthy for you to perform, go for timed up and go test. We know. Ask the patient sit in a chair, up, going around. You have a cone, and then coming back and then sitting, timed up and go test, and the amount of time he is taking, and what kind of mistakes he is doing or errors he is doing in it. Functional reach test, ask him to stand supported to a wall, and then ask him to do this, no? And then ask him to reach forward. Mark. Without falling balance, amount of distance he's able to reach forward, functional reach with the hand, you mark. You mark the initial range, you mark the final range, and you see the difference. With every therapy session, you can see the difference. Box and block test is where you have a full box, which is partitioned into two. One half you have full blocks, and then the other is empty. In 1 minute, each block, the patient has to put from a fully filled compartment to an empty compartment. So the amount of time the number of blocks he can put one by one in 1 minute is box and block test. Pegboard, Purdue pegboard test is in 30 seconds. So there are 3 components. Either you ask him to use right hand or left hand or both the hands, depending on the hand dominance also. In a Purdue pegboard test, for example, in 30 seconds with my right hand, I have to put, you have the pins and you have the pegboard. Pegboard is where you have the board with the proper sized holes where you have pins, you have pegs, you have collars, you have other bolts where you have to put in those respective sizes. Correct? So in 30 seconds with right hand, how many am I putting? Best of 3 attempts. Or in 30 seconds, how many am I able to put in the exact shape with my left hand? Best of 3 attempts. Or if he finds it difficult for with one hand, give him both the hands. Both the hands, he has to put those in a proper pegs in 30 seconds. So you, best of 3 attempts, you can check for the coordination. This will tell you a fine coordination, a fine motor coordination, because it's very important. And these scales are very easy. You don't require too much of equipment. As I have already mentioned, there are certain scales like your Solomon hand function test, action research arm test, Franche arm and hand activity inventory. These scales require high equipment. You have to have certain door handles at certain dimensions. You need to have blocks of certain dimensions, wooden blocks, aluminum blocks, steel handles, round locks, and a long handle blocks. Very tedious for you to manufacture them. You can't sit with a carpenter and get it done for every patient. It has to be customized for every patient. That is why these scales for fine coordination can help you in understanding the grip and also understanding what activities or exercises you should give to improve his or her grip. Gait, see, I'll finish off in maximum in like 5 to 10 minutes. I'll not take much of time. Let me just grab a little bit of water. Right. In Gait, what will you assess? It's not up to me to tell you. You know it very clearly. Time variables. When I say time variable, single support time, double support time, distance and time for mid swing to acceleration or acceleration to mid swing to deceleration, time in seconds have to be noted. Distance variables is where you have stride length, step width, degree of toe out. These come under distance variables. You have to test them, you have to measure them. How will you measure? Put a long piece of white paper, long white sheets. You get these white sheets or white chart papers also. You can apply, put 3, 4 chart papers in a row. Ask the patient, and you put a water, a tub or tray of water, colored water. Ask him to dip his feet and then walk. Dip his feet, dip both the feet, and then he has to walk normally. He has to walk. He need not go for tandem. Ask him to walk normally, and then you can measure. Okay, that's the simplest way how we learned how to assess. Sorry. While walking, check for any synergy pattern. If yes, tell the patient what synergy pattern, or you understand what synergy pattern the patient is having. Either there is loss of pelvis movement, there is loss of lumbopelvic rhythm, there is loss of hip flexion, there's loss of knee flexion. Even if everything is there, there is loss of arm swing. Use of any compensatory movement. Is a trunk lurching too much? Is a shoulder being shrugged too much? Right? And if the pelvis is or hiking of pelvis is way too much than how a patient should be ideally using. See, he can cheat for a while or for some degrees. 1 or 2 degrees cheating is okay because ultimately we want him to recover. It's okay if he cheats 1, 2 degrees, but he cannot cheat completely. Walking with a complete trunk lurch or walking with a complete shoulder shrug, walking with a complete hip hike is not considered. Type of pathological gait also you have to mention, even if it's not a circumductory gait, even if it's an antalgic gait, even if it's a say gluteus medius weakness gait. Mention that. Stroke patients can have that. Like, for example, Thomas had a dragging kind of a gait. I told you. It's okay. He came to me with paresis, but he didn't show any circumductory gait pattern. Scales, what you can use are dynamic gait index is my favorite. It's very easy. The dynamic gait index is very easy to perform. It has 8 items and total score is 24. I've made a note because I cannot forget everything. And these 8 items will be walking straight, walking in the usual common speed, walking a curvy, walking in changing speeds. You will give them instructions. Walk fast, walk slow. Walk fast, walk super fast, walk super slow. And then look horizontal while walking, look vertical while walking, change directions immediately. You're walking and suddenly 180-degree. And then obstacle training, overcoming the obstacle or going around the obstacle and walking. All these are the parameters that you check in dynamic gait index, and out of 24, you can give him the scoring. We know that what 6-minute walk test can be done. It's very easy. In 6 minutes, you have one cone to the other cone. How much can he walk? And any errors or any difficulty he's having, fatigue, dyspnea, breathlessness, or dyspnea and breathlessness, one the same. Loss of consciousness, pain, uneasy sensation, vomitings, headache, any of that, immediately you stop the test and you note for how much, how long was he able to walk in the 6 minutes. Fatigue severity scale is a questionnaire that the best part about questionnaires is the patient can fill by themselves. You need not involve in that. Okay. So fatigue severity scale is where what activities that you do not find weak while doing, what activities will tire you, what activities that you do not want to do because you feel tired. These come under fatigue severity scale. Okay. So this was about gait. After gait, what will you notice? My favorite again, ICF. In the ICF, you have to check for body structure and function. What is the impairment that the patient has come to us with? What is the impairment he's still presenting? What are the activities that he or she cannot do? And what is the participation restriction? Even if he or she can do, what are those activities they are not doing? Even if though they are capable of doing, what are they not doing? And what are the reasons for that? Is it the environment or is it the personal factor? See, for example, if a person can get up and go out and buy groceries, he can do. But why is he not doing? Is the environment like that? Which means, is the social environment like that? Are the neighbors making fun of him, or people are very rude towards him, or he himself feels, why should I go? Why do I need to go? Or he himself is depressed. That is what you have to understand. For that, you have to give them the activities. That is why I've written Barthel Index and SF36 questionnaire. SF36, again, short form 36, the patient can fill himself about mood, productivity, work, the social interaction, what are the activities they can do themselves. All these will be covered under SF36. Barthel Index, 8 items: grooming, hygiene, bowel and bladder. Again, bowel and bladder I have missed. Bowel and bladder training also you will have to incorporate before your gait and balance. Bowel and bladder. What is the bowel output, bladder output? What is the restriction in the bowel? If there's a constipation, if there's loose motions or diarrhea, you have to mention those. Coming back to ICF, in the environmental factors, facilitators and barriers. When I say facilitators, what are those that are enabling him? For example, say positive neighbors or kids. Kids are usually facilitators in a society. They are never disablers, they're enablers. Because you'll see any old age people walking, kids are very supportive. They go along with them, irrespective of their family or no, even if they know or do not. So kids and supportive neighbors, they act as facilitators. Barriers are, say, high traffic or high infrastructure, or too long to walk and come back, no proper footpath. These are barriers. Personal factors also, you have facilitators and barriers. Facilitators are positive family, positive output, and he himself seeing the change is a facilitator. It motivates him. Barrier, depression component becomes a very important barrier. Check for depression component also. Very, very important. And Bartholinics and SF36 questionnaire will help you in understanding what are the ADL activities he can do or she can do by themselves and that require assistance. This is one component I have to focus on. I want all of you to focus on going forward on your patients is kinesiophobia, fear of activity. Most often, even a normal low back pain person, even if the person has a low back pain for as less than as 2 days or 3 days, because of pain, they stop doing certain activity. You have to understand what kind of pain avoiders they are, or fear avoiders they are. Learned pain avoider, existing pain avoider, catastrophic pain avoider. There are many kinds of fear avoiders. You have to, there are classified mainly 3 categories of fear avoiders. You'll have to categorize under them. What are the factors limiting their activity? Is it only the pain or fear associated with pain, or only fear? Sometimes chronic pain leads to fear. So you should know that if the fear is stopping, or if there's really a pain that is stopping. Here you can go for list of activities done independently that requires 1 support system and 2 support systems. The best scales that work here is Tampa scale of kinesiophobia and fear avoidance belief questionnaire. Both of them are very simple questionnaires to fill by the patient themselves. Tampa scale has highest reliability and validity. I use this on 2 of my studies. Therefore, I suggest you use these scales. It's very easy to administer. It's very easy to count. It's very easy to see the improvement also. But work on their fear component. Fear one, both of them are questionnaires. Wherever there is a questionnaire, it's for the patient to fill by themselves. You need not administer. Like, say, modified Ashworth scale. You have to administer. Tampa scale, they can do it. They just have to tick. How I fear a lot to get up from bed. Tick. I fear a lot to eat by myself. Tick. I fear a lot to shower myself. So it goes from 0 to 3. 0, no fear at all. 3, highest fear. Okay. So that's the Tampa scale of kinesiophobia. Check for depression. Beck's depression inventory, hospital depression inventory scale is also very, very impactful. You can check for these scales, but please make a note of Tampa scale and fear avoidance belief questionnaire. The last slide for today, we have stroke specific scales where there are many, but I have just got basic important scales for you to understand that even if you don't test for all the others, test for these and you will know the improvement. Stream is known to be the first, the earliest, and the most widely used scale before Fugl-Mayer. Stream has been very, very easy to administer. Today you have modified stream also. Stream itself is very easy. It has coordination, it has mobility, range of motion, upper limb mobility, lower limb mobility. These are the components in stream. Stroke rehabilitation assessment of movement. That's short form is stream. Basic mobility, upper limb, lower limb, trunk, all of these are tested in supine, sitting, and standing. So this stream, it targets mainly coordination, range of motion, and mobility in a patient. Here, this stream scale does not target on the synergy pattern, but he or she is asked to perform these activities in supine, sitting, and standing. Basic upper limb activities, basic lower limb activities, coordination, and range of motion. Based on that, we total the score. And as the score is improving, the patient is also improving. Lesser the score, the severe is the patient. Fugl-Mayer assessment is a long scale. It's a very in-detail scale. It is about 155 items and it is done post-stroke again. It has 5 domains and it has 155 items in total. So if you have ample of time, you can do it. Or if you have a large team with you, you can go for Fugl-Mayer. Otherwise, stream is very good. You can use stream. I'll tell you what are the other scales also that you can use. But in Fugl-Mayer assessment, you have motor function, sensory function, joint range of motion, balance, joint pain, mobility. These are the five domains that they work on. So we have motor function, sensory function, balance, joint range of motion, and joint pain. These are the 5 components under which you have 155 items that you have to ask the patient to do and they have to execute and they have to do, and then you will have a scoring. Again, Fugl-Mayer can be broken down. You have upper limb separately, lower limb separately, trunk separately. Therefore, only for upper limb, if you have, that's one advantage of Fugl-Mayer, where only for upper limb, if you want to use, you can only take that part. It has bifurcations of upper limb, lower limb, and trunk, where stream does not. Everything is into one entity. Scoring is also everything. For Fugl-Mayer, scoring is also independent. Upper limb scoring is different, lower limb scoring is different. But for stream, unfortunately, it is a complete scoring. Therefore, that way, people today are using Fugl-Mayer more than stroke because of independent testing. Okay. Then you have stroke specific quality of life scale. Again, because after stroke, how did the quality of life change is a questionnaire that the patient has to answer to himself because he knows well. This will focus on the mood of the patient. If the questions that they ask targets the mood, it targets the productivity, it targets the social interaction after stroke. It targets the how positive does he or she feel every day, even during therapy or even without the therapy. Therefore, you will understand the mental morale of the patient, and based on that, you can guide him or her towards the ICF model and then towards ADL training. But these are not the only scales. You also have stroke impact scale. You also have trunk impairment scale. You have motor assessment scale. Many National Institute of Stroke scale. There are many scales for stroke, for cerebrovascular accident, and these will help in and you can pick anyone, but these will help in understanding what is the severity of stroke according to the patient, what he or she feels is the severity, and how can I improve that. There is no hard and fast rule that you have to follow all the points of assessment, but you can follow at least these stroke specific scales for the, if you do not have other modes of assessment, if you have these scales with you, just implement these scales, test these, you will have an idea where is he or she lacking, what needs improvement, what is good. You can target the good, you can target the improvement more. So wherever patient is good, resistance, give more of resistance to that, or resistance training to that. Wherever you feel that the patient is lacking in something, target that. Okay. So these stroke specific scales will help you in your masters also. For example, you have to do thesis. These scales are easy. They have very good validity, reliability, sensitivity, and specificity. Their ICC correlation coefficient is also very good. Therefore, you can go ahead and implement these scales. And that's it from my end. Let me just stop sharing my screen. I believe that this has given some insight to you with respect to the case study, did Thomas recover? Thomas, yes, he did recover. Naming Agnosia actually got really better. His gait also got better. He's again back to his work, and yeah, he's doing really good. He's again back to his hometown, and he's again back to his old occupation only. So on this good note, I would like to thank all of you for paying attention for the last 1 hour. And any doubts, you can write to us directly. And if you feel that some topics would require a re-lecture, we'll arrange a re-lecture. Thank you so much. Have a great rest of the day.